After listening to all these talks, I would like to focus my talk rather than what I have prepared today about my journey, what I have done in UK with regarding the evolution of EMR, ESD, and early detection, and what is called the MDT meeting. So, as you all know, colon cancer screening has started from UK and has been spread all over. So, to make things easy for you, what I would initially thought of making it like a DDW meeting, but having said this, I just want to just give the history of what we could do with evolving into things. So can I ask how many are surgeons present in this room, please? So that I can able to, so majority of you are surgeons. Very good, excellent. So I would just skip all these things to actually give the perspective of what the gastroenterologist or endoscopy should do. So my journey while starting this one is all about evolving things over the last 2 decades. Is what they did was they try to understand whom to biopsy, how to biopsy, what strategies you got, all these latest technologies that's coming come into practice only you know when, how to use them. So forget about all these things, and I'll only give you 1-2 algorithms to say. So initially, my strategy, what I'm finding here is mostly the patients come with just focusing on EMR, ESD, and surgical referrals. That's all I'm going to talk about it. How we put the practice of 22 years experience of UK into what's going to evolve in this country and how we screen them. That's all I'm going to say. Forget about all these things I have made here. So to start with, majority of the patients here who present, they already have problems, swallowing problems. So that you go with a PET scan and then implement what it is. So either you have to decide they are going for palliation, they're going for surgical. So don't spend too much time on wasting these patients trying to take. When I first came here, some colleagues was taking, I took 75% of this cancer away. What's the point in doing that? It's just creating unnecessary bleeding risk. So from that point of view, I think what's your role as an endoscopist? Is it palliative role or is it surgical role? You just need to create a multidisciplinary meeting. That's what they do. In UK, what we have evolved over a period of time is screening program, especially the Barrett's is quite common in UK and Western population. Here, the smoking and alcohol, what contributes to majority of this one, and especially in Northeast India, they have this gutka and all these things which contribute to upper GI squamous cell carcinoma. These patients have completely different evolution. They wait for dysphagia to develop. And how many are involved in treating patients from Calcutta here? How many do you get an average? Majority of them squamous cells. How many do you treat them here? Can somebody rise? Between adenocarcinomas and squamous cells, which is the majority you see in your routine practice here? Nobody wants to participate in that. Squamous cell, yeah, exactly. So these patients don't actually present a bit early. They present a bit late. They already have dysphagia. You're actually only trying to see, because the finances do come in India as a factor, to see whether they could able to go for all these procedures, so that whether you're going for palliation, what is the lifespan, that's all you're going to look at it. In UK, what we do is we have Barrett's, and we have Barrett's surveillance specialists who do those things, because the Barrett's endoscopy does take around 20 minutes. The reason is that while using all those fancy gadgets that we have, the cleaning, Lugal, acetic acid, and all those things, because you need to allow the dye to sink in and then use your other algorithms to see what you are. And then you focus your biopsies. One of my colleagues has rightly asked, is this sampling error? The sampling error is not because of that. It's because of the time we spend and the protocols we use. So endoscopies are selected based on, yes, you are doing a Barrett surveillance list. That means your number of patients that are allocated on that list is reduced. And also, if I'm doing a polypectomy, I used to do 2 or 3 sessions a week in UK for polypectomy, because you have to specially train for polypectomy, because they only allow people who are trained in bowel cancer screening to tackle those things, because you cannot half resect them, because if you have recurrence, then you get into trouble. So EMR has high recurrence if you don't choose the patients appropriately. The reason I'm trying to create this image is like, just remember, the relevance of this one comes from the EUS. Everybody talked about T1A and T1B. Just remember as if you have tiles at home. So you want to put a white marble. So all the white things are mucosa and submucosa. And the ones that you put the plastering cement, what you call them as muscle layers. So they have different layers. So when you do this EUS, you just see which layer they are in. Is it something I can able to resect? Does it need? Is it too big? Then it goes into the ESD. Am I competent to do that? Have they got big vessels beneath it? Am I going to cause the complications? Don't attack anything as a gastroenterologist. Go into it. If you think that you're going to create a complication by bleeding or perforation, don't even touch it, because ESDs is not for everybody from my point of view, because it needs a high training. So